with Good afternoon, everybody. About to get started here in a quick minute, but is Dr. Lachlan on the line?
I'm on here.
All right, sounds
I'm looking
great.
for Dr. Ainsworth.
Sorry?
I'm looking for Dr. Ainsworth, my colleague as well. I don't know if
Oh,
she,
okay.
but she might not be able to unmute herself. So
Let me see if I can find her here.
there she is.
Okay. All right. Well, good afternoon, everybody. My name is Ian Mwangi, and I work with the Office of Education, Diversity, Equity, and Inclusion. And we're excited to host this session today on medical ethics. And we actually have our Associate Dean for Diversity, Equity, and Inclusion, Dr. Shannon Lachlan Tomaso, who will be kicking us off with this session and has a couple amazing cases that she'll share with her colleague, Dr. Ali Ainsworth as well. So just kind of kick it off. I know we have kind of a short amount of time this afternoon with you both, so I want to make sure we have enough time. And then if you do have a little bit of time, maybe would you have some time for Q&A if folks have some of that, or do you want people to kind of put questions in the chat?
Yeah, feel free to throw questions in the chat while we're going, and we'll kind of watch while the other person's talking, maybe try to monitor some of those. Yeah, and at the end, we'll try to save it. I'm so sorry we have to cut it short today, but there's only 30 minutes we have. So,
Sounds good.
Allie, why don't you introduce yourself if you don't mind while I pull up the slides?
Yeah, I'm Dr. Ali Ainsworth. I trained in OBGYN and then did a fellowship in reproductive endocrinology and infertility. So broadly speaking, there's a surgical side and the infertility piece, in vitro fertilization, IVF may be a kind of common term you're aware of. That's the type of care that I do.
And okay, good. I'm still off mute. I'm Shannon Lachlan Tomaso. As Ian said, I'm the Associate Dean for Education, Diversity, Equity, and Inclusion at Mayo. And my day job is in gynecologic surgery. So I do some of the things we'll talk about in these ethical issues are sterilization procedures. So I do some of those procedures as well. So let's go through that. So we're super psyched to be here today. We want to start off. I'm actually going to start off with a disclaimer. We are not bioethicists, but we are practicing clinicians who face ethical decisions on a regular basis. So we wanted to just share with you some of the things and some of the important reasons why when you're going into medicine that ethics is really important to learn about and to think about and to take pretty seriously. I think sometimes it's part of your prereqs, but it is a great opportunity to start thinking about these issues. And then I'll go back to our learning objectives. So we'll review some of the historical perspectives that might influence biomedical ethics, because I think that pulls into it a lot. So when we talk about diversity, equity, inclusion, and anti-racism, there are a lot of historical perspectives from the US in particular that have created situations in which it has changed the ethics in medicine. And then we have some interesting cases that require an ethical lens to look at. So in medicine, when we talk about ethics, we talk about the 4 principles of ethics, which is respect for patient autonomy, beneficence, non-maleficence, and justice. But there's a lot more frameworks coming out that are really important. So virtue-based ethics, the ethic of care, feminist ethics, communitarian, and care-based reasoning. So these are all different kind of frameworks to look at when you have a problem. But the traditional one that we kind of learn about is like making sure that patients understand that they have choices, trying to, make best choices with your patient about things and also not do any harm. And then think about ways in which we treat justice within the ethical system. So it could be more of like resource use, utilization, and those are things that our residents and fellows in practice are actually like kind of evaluated on. And the main things we think about with ethics is situations of informed consent. The consent is a piece of paper, but the informed process of being able to have a patient really understand the risks and benefits, that's a huge ethical dilemma sometimes. Confidentiality, conflict of interest. So if I was sponsored by some company for a procedure I did, and I only did that procedure for patients, that would definitely be a conflict of interest. But when we think about it, all these different things come in, like legal guardians and adolescents, who signs the consent, having privacy in the electronic health record, especially if you're a teenager. Who gets to know what and at what age does that start to change? Privacy laws. I know Allie's work, Dr. Ainsworth's work in IVF, there's a lot of things about privacy and HIPAA that are really challenging. So I'm gonna have Allie go through the first case. And this is a little bit of what I call genetic disclosure. She did not call it that, but do you want to present the background or do you want me to, Dr. Ainsworth?
Yeah, I can start.
Okay.
I'll pick up here. So this case is a patient that I met last week. And the patient who I met is female. Her husband's mom, we gotta follow the train here, has Huntington's disease. And just to familiarize ourselves, Huntington's is an inherited genetic condition. It is autosomal dominant, so most of you probably know, but to remind you, you could just have one abnormal allele and you have the symptoms, you have the phenotype of the disease. It's a neurodegenerative disorder that has characteristic movements, psychiatric issues, dementia. Depending on the number of these CAG repeats, symptoms can start in early childhood, but more often in middle age. Importantly, there is no cure. 5 out of 100,000 individuals have this condition. We can go to the next slide. Dr. Laughlin's writing in the chat, has everyone heard of Huntington's? So we'll talk more. I mentioned this autosomal dominant. So here's our Punnett square. Mom is across the top on the x-axis, dad on the y-axis. And we can see, right, mom and dad each send an allele to a potential child. In an autosomal dominant condition, 50% of children statistically would be affected. So we'll keep going. And I think the first question that came up in my consultation with these patients is the partner, the husband in this relationship doesn't want to be tested, which isn't uncommon. We can all imagine, right, the psychological impact of knowing you have a disease that will impact you and your family, and you don't know when it will start in terms of symptoms. So not uncommon, especially for a disease like this. Other things that kind of fall in the realm of this disease are ALS, right? These really catastrophic diseases that have no cure and have symptoms, but the age of onset is unknown. So they came with a few questions, and they were really a very thoughtful couple to say, first, we're both in individual and in couples counseling to decide if we even want to have children, because he doesn't know if he carries the gene or not. And he knows what it's like to live with a parent who has this degenerative disorder. So they're working through that as a first layer. The second thing that they came to talk about was, they said, I've heard you can do IVF for genetic testing, and you can. So this is the next slide. On the right, left side of the screen is a picture of an embryo. Again, to familiarize ourselves, a fertilized egg is called an embryo. So when we do IVF, in vitro fertilization, an individual, the person with ovaries, does multiple injections at home. In general, 2 a day, eventually 3 a day on average for 10 to 12 days. Then we do an egg retrieval under anesthesia. We take out the eggs, not all of the eggs that woman has, just those that are available that month. Combine them with sperm. A fertilized egg is called an embryo. And embryos develop in the lab to this stage called a blastocyst. A blastocyst stage embryo has 200 plus cells, and the cells have differentiated. So that outer ring will become the placenta. That's where we take a biopsy from. So we take 5 to 10 cells from this 200 plus cell embryo, not the part that becomes the baby, the part that becomes the placenta. And we can do genetic testing. You can do something called PGTA, aneuploidy, looking for overall chromosome number. In this scenario, you could do something called PGTM for monogenic disease. So if he wanted to know his carrier status, he could be genetically tested, and we could develop a genetic probe specific to his mutation and then test embryos. But he doesn't want to be tested. So we can do something called exclusion PGT. And that's what this image on the right shows us. So in this example, Leanne is the mother who has Huntington's, so her alleles are in red. Larry is the dad who is unaffected. Eliza is the patient. So in my patient scenario, Eliza is the husband that I mentioned, but this is the child who doesn't know their carrier status. Eliza, in this scenario, partner Eric, has no abnormal alleles. So in exclusion PGT, exclusion IVF with biopsy, we can identify genetic markers on, in this example, mom's Leanne's allele. We are not testing specifically for the Huntington's mutation. We're saying, does this now embryo carry an allele from Leanne? If so, we're excluding it. This is now a high risk embryo as opposed to low risk. It is not, again, diagnostic of Huntington's. We will exclude more embryos from transfer than we would otherwise, right? Because not all of Leanne's alleles are impacted. But it's a way ethically to kind of protect the patient from not knowing genetic information that they don't want to know, while also mitigating transmission of the disease to future generations. So there are some unique cases, and when you also think about what I do with IVF, can involve donor eggs, donor sperm, gestational carriers. There's a lot of ethical questions and situations that arise that are really interesting and kind of fun to work through.
So Dr. Ainsworth, really quick question on this. So this is really interesting. So in your scenario right now, we're pretending Eliza is the one who has potential for Huntington's. And Eliza technically doesn't want to know, but if she did want to know, we would already be able to genotype her. And if she doesn't have the disease, then they could go on and have babies without IVF, right?
Correct.
If she does have it, then you could test the embryos specifically and kind of know, right?
Mm-hmm.
But in this situation, this is really cool. So any embryo who basically gets information from the affected grandma is the one that you exclude, even if it's not the Huntington's gene.
Right. So
That
we're excluding probably an additional 25% of embryos that we otherwise wouldn't necessarily have to.
Mhm.
But in doing so, we're preserving Eliza in this scenario's autonomy to decide, I don't want to know that information about myself.
That's really impressive. And at a higher level than I understood the other day when I talked to you about this. So does anybody have any questions about that process or how that works, and or other questions about the recordings? And you can either, I don't know if anyone can undo it, so you might have to ask in the chat. So feel free to put a note in the chat. And then what other testing do people get if they donate sperm or donate eggs? Is there genetic testing for those?
There is now something called expanded carrier screening. So Huntington's is an example of autosomal dominant disease. Expanded carrier screening tests for genetically recessive conditions. So in that type of genetic disorder, you have to have 2 abnormal copies to have the gene. So if in our scenario, Eliza and Eric both have the same abnormal copy of the same gene, they each carry the disease, they don't have it. They have no symptoms because they only have 1 copy. But now if we think of that Punnett square again, 25% of their children would be affected. These are things like cystic fibrosis, sickle cell anemia, are common examples. There are panels of now 600 plus recessive genetic disorders. Oh, it's a little bit confusing. I don't think, I'm going to finish this thought and then I'll try to clear it up a little bit. The genetic recessive disorders are common, and it depends who you are working with in terms of gametes, donor sperm, donor egg, donor egg, donor sperm. You could see their genetic test results and then select a donor who doesn't have a shared mutation to you. And that way you're not increasing the risk of genetic disease transmission. But to back up a bit, I don't think it's so much knowledge of the disease as, to me, understanding that in this specific scenario, it is a disease associated with neurodegeneration. So these people will lose their cognitive abilities, they will lose their memory. They are early 40s onset of dementia, psychiatric conditions, movement disorders, and it is progressive. So the symptoms start mild and they progress and result in death. with no treatment, no cure. That doesn't exist today. So the point is, if someone carries a genetic mutation, only one, they have this disease. There is a way to mitigate transmission of that disease to offspring without finding out whether or not you're affected. Because knowing you carry that genetic information may or may not be helpful to you, right? Some people would say, I would like to know I have this. I'm going to make different decisions for my life if I know I carry this genetic gene, this genetic disorder. And others would say that adds a lot of psychological distress to me to know that I'm going to develop this and I don't know when. I would rather not know. So from a medical ethics perspective, there is a way to both protect that person's autonomy and give them reproductive choices that eliminate transmission of the disease to future generations.
And I think you might have been responding to a question that was maybe just sent to you. I didn't see one in the chat, but.
Oh, sorry. The question said it's a little confusing as we don't have enough knowledge of the disease, which is why I thought we could.
Yeah, it is. That's a great question. Yeah, it is very frustrating. There's a lot of diseases out there like that, unfortunately, that we don't have enough knowledge. We don't have a cure. Most of them you don't know for sure you're going to get because they are autosomal recessive, which means that just 1 in 4, like if the stars align where you get the same recessive genes, then you would have it. But in this situation with the autosomal dominant, basically, if you have one allele of it, you do get it. So, well, thank you. I know there'll probably be more questions in the chat, and I will tell you guys, I'm struggling a little bit to get my chat bar back. So if I'm late on the chat, just let me know. But I'm going to move on to the next scenario that we're going to talk about today. And this is the case of sterilization, or like more commonly known as either vasectomy for men or tubal ligation for women. So getting your tubes tied is a lot of how women talk about it. But technically we call this sterilization, which means like actually ending the ability to bear children. And I'll talk a little bit about some history on here. And a lot of what I'm getting is from this awesome article that was just published last fall by Dr. Nioli on a historical primer on OBGYN health inequities. And traditionally, OBGYN does not have a very good historical record on treating patients, especially of underrepresented groups or marginalized groups. And we acknowledge that. So there's a lot of information out there about how history has influenced how we do things. And I still think there's a pretty strong impact today. So I'll present a case. I have a 24-year-old who is currently pregnant. She presents to labor and delivery preterm, so at 34 weeks. Term is 37 weeks and above, and she delivers the baby. And she had wanted a tubal ligation. She is on Medicaid insurance, and she signed the Medicaid consent 5 days ago. And just for reference, you're supposed to have that consent signed 30 days before the procedure is done. So let's go back a little bit in history and tell you why that is, and why this becomes sort of it's not even so much an ethical dilemma, although there's a lot of ethics around the situation. So back in the 1900s, there was a eugenics movement, which was said to, the reason was to maintain racial hygiene. So there was this belief that there's an inferior group of people, which are people of color, indigenous people, people with disabilities, and low income. And this control over people who were allowed to procreate were like codified into laws. So anti-miscegenation laws is basically where people from different races could not marry. There were birth control campaigns that actually forced birth control on people, and then government forced sterilization, which I'll go into a little bit. So one of the Supreme Court cases was Buck v. Bell, which legalized sterilization of inmates of institutions supported by the state. So not just prisons, but also mental institutions. And of course, we know that like not everybody who are in institutions should necessarily be there. But when we look at state laws, some of those were just as severe, or if not more severe. So in California, there were about 20,000 sterilizations, which are disproportionately Black and Latinx. Mississippi, there were 683. Most of these were hysterectomies instead of myomectomies. And that was back in 1928. In the 60s and 70s, the Indian Health Service reports that about 25% of Indigenous individuals were sterilized, basically against their own wishes. This was sort of forced sterilization. And as recently as 2020, there's been allegations of forced hysterectomies in Georgia in a detention center. So people went in thinking that they were just getting their fibroids removed and actually had their whole uterus removed. So these are some really horrific history of sterilization. So in the 1970s, the Medicaid sterilization policy was made, and they basically said if you are on Medicaid insurance, to get a sterilization procedure, to decide on your own that you want a tubal ligation, you had to sign this form, men and women, so vasectomy too. And then after you sign the form, you had to wait 30 days. And the wait is to make sure people understand the implications of it. So it's a little bit, it's supposed to be for like teaching. So people really know that they've decided that they're going to do this. And in the form, it actually says that this is not reversible. The only way to get pregnant after this procedure would be to do some in vitro fertilization with Dr. Ainsworth's group. And that, by the way, we're not going to cover that. So it has to be like a permanent final decision. Well, that limits the fulfillment of the procedure. Only about 50% of women who sign the form actually go get their request fulfilled for various reasons. Sometimes it's loss of insurance after pregnancy. It could be delay of getting access to care. It could be, there's some indications that in the first year, people who had the form signed and wanted it done but didn't get it actually have a higher pregnancy rate than people who don't. So like they really didn't want to have another pregnancy and then weren't able to go through with it and then got pregnant. So there are some reasons why like people can't fulfill it now. So there's a lot of push to say this 30 days is not fair, that people on Medicaid should have just the same rights as everyone else. Because if you have commercial insurance and you sign the form, you can get the procedure the next day. So, but there has been some emergency allowances for early delivery, and the fight back for the Medicaid policy is because of all these illegal sterilizations that happen for centuries. So it's kind of the current situation. The American College of Obstetrics and Gynecology actually raises a lot of teaching about ethics. So now all of our residents and fellows go through ethical training in didactic sessions, and they talk about these situations. And the first thing they say is that respect for autonomy should be prioritized. So center the patient's wishes, but you should also talk about non-permanent options so that they know what their options are. And as I mentioned, in this case, this patient knew she wanted it. She signed the form and then she happened to deliver early. So there is an emergency exception. So we totally could do the procedure for her. But they outright say that people need to take in their understanding of their own bias when they're counseling and avoid actions based on biases. So don't assume that just because she's 24, that she doesn't want to have this procedure. And that's been a huge pushback. There used to be a lot of people who said, oh, you have to be there was a calculator, actually, a certain number of pregnancies you had in a certain age before you get it. But actually that ACOG now says that it's permissible to perform a sterilization even in women who don't have children or young women who do not wish to have children, because it's really centering that person's request. Like they can say, I don't want to have any children. And in the past, it used to be like a mental health consultation would occur. And now you can just say, look, people understand the risk of regret. They understand their decisions and they get the right to make that decision. This is a lot of words, but basically just if an institution does not provide sterilization, like there's some religious institutions in the country who actually don't do tubal ligations, you need to let patients know as early as possible so that they can go elsewhere for their care, especially if they're going to, if she presented early to an institution that doesn't provide sterilization and she didn't know that, then she has to come back to a different institution after delivery. And then they actually say only rarely should incarcerated women, because there used to be a lot of pressure on incarcerated women to get sterilization procedures where they would actually offer them to lower their sentences if they went through with this. So it's very rare that you should offer someone to undergo sterilization while they're incarcerated so that you don't have a coercive environment. And if someone has signed the forms before they are incarcerated, then there's a possibility of getting it during it. But otherwise, we have to be really careful that they haven't been promised something or coerced in a jail or prison setting. So some really interesting ethical issues surrounding that. So back to the case. In this situation, I kind of already gave it away. I forgot I had the slide, but throw it in the chat. Like, would you feel comfortable doing the tubal ligation, given the surrounding issues that this form has only been signed for 5 days? Just let me know what you guys think, or you can send it to me privately. But as you're considering that, I will go on. Any questions before I move on from this?
Can you see your chat?
A little bit, yeah. It's really,
Yeah, I think someone sent it to me. One said, we need to respect the patient's autonomy while trying to do what is best for the patient.
that's right. Okay, good. Yeah. Yeah, so it's interesting. I'm getting some personal responses too. And I think it's really interesting, like how people feel about this situation. So there is that emergency clause. You could do the tubal ligation if the patient has any hesitation. And I talk about this in my clinic all the time about hesitation and regret. So regret is actually one of the biggest reasons why people would have the concern about, down the road, they would have regret of doing this because it is not reversible. But when people have really kind of told me that, they understand the risks, then we can do it. Yeah, I'm seeing some really good direct messages to me about like, as long as the timing is or the risks are understood, regret. Yeah. Very good. And I know like this is a tough topic. I totally understand why people are direct messaging me. And I don't know, maybe you can't also do everybody, but I love the responses I'm getting about we have to think about the consequences and everything. So, all right. Well, in the last couple minutes, keep sending me messages. I'm really enjoying this. Oh, I have a good question, actually. Let me answer this one real quick. So what if the patient is not sound of mind? So that's one of the reasons why people want the consent sign well in advance, is because to make sure they've made the decisions not under the coercion of like during a C-section or during an emergency setting. But cognitive impairment or having, someone else's legal guardian, like somebody else is your legal guardian, you actually do have to get a court order. So that's a major legal process. So if I was an adult and was not able to make my own decisions, and say Dr. Ainsworth was my legal guardian, she would have to make a decision for me, but she would have to go through the court system to prove that this was needed to be done, that there weren't any alternatives, things like that, and that they have assessed the situation. And then I really, I can, as far as I can understand what's going on, I would understand that, but also that she has thought about all the other possibilities, because there were another historical aspect was forced sterilizations of people who were claimed to be cognitively impaired, but actually weren't. So we have to be really, really careful in that situation, that a legal guardian cannot just like say, I want her to get sterilized and have the procedure happen. So it is a big process. Okay, I have one more question here. Yes, at any time, if you think the person is being coerced or you're not sure, you absolutely can kind of investigate more. And that's one of the things I actually really do like about having a protective layer. So right on the top here, I talk about ethics consults. So if we have a situation, and I have called them in for a procedural question before, if there's an ethics committee that we have, and there's an ethics consult that you can do. So they would come in and they would actually interview all the parties. So they would interview the legal guardian, they would interview the patient, and try to figure out what kind of situation is going on. And then after the ethics committee, if they say, yes, this procedure could go forward, if it's a legal guardian situation, that's when it goes to the legal situation where they go to court. But before that, it has to have an ethical consult. So yes, you absolutely, if you have concerns, you don't ever have to be forced to do a procedure. All right, so the rest of ethics training, and Ian, I'll get to your question, but that's a big one for 2 minutes left. We get didactic sessions in this. We have journal clubs that can surround it. We have the committee opinions from ACOG, and then there's a lot of advocacy groups. So as Ian mentioned, there's a lot of change in laws happening in different states that is actually impacting a lot of people. So people are coming forward and looking for more sterilization procedures at younger ages because they are concerned about the abortion laws in the country. And so we've had patients outright state that. There's a lot on social media. It is impacting things. I do think there's going to be some changes to the length of time that somebody has to sign the 30-day form in the future. But it's hard in this environment to know what's going to happen legally. So I'm sorry, we could talk about this topic a lot. We're going to have to go soon, but Dr. Ainsworth, I want to toss to you any closing thoughts or.
No, I think the last question by Ian, as you said, is a big one, but a push, right, that we can advocate even from our computers and send those pre-written emails to legislatures. So there's lots you can do, you know, no matter where you are to impact the things that are important to you. And I think from our perspective, right, reproductive freedom and choice is ethically relevant and needs protection.
Yes, thank you for bringing that. I forgot Dr. Ainsworth has actually done a lot of advocacy work with our local government. I don't know if you've gone to the federal level yet, but in terms of in Minnesota has gone to the Senate. Where'd you go? Tell us a little bit about it.
We went, Minnesota had a bill, I don't know that it's going through for financial fertility coverage. So we went on advocacy day and met with our local representatives, and there has been a bit of conversation back and forth. So between myself and the representative, so I feel like even if it's not going to go this year, we're doing what we can and making a difference, trying.
Well, I just want to thank you both for this outstanding presentation and just sharing some amazing cases. I know these are very difficult conversations to have, and also some cases that you're currently dealing with. So I think it gives us an idea of some of the ethical issues that you're presented with as physicians in this field. So really appreciate you walking us through these cases and really explaining some very challenging and difficult ideas and concepts and experiences. But I just want to thank you both, and hopefully we get another opportunity to have another conversation similar to this in the future. But for the rest of the audience, if there are additional questions, feel free to send them to us. We'll make sure that Camille gets our contact information to you all. So if you have additional questions about this topic, we can definitely answer them at a different time. So just thank you again so much. And also thank you for your advocacy and the work that you're doing. I think it's important as physicians to really, advocate for your patients and their patient rights. So I really appreciate the work that you all are doing in this space as well.
Thank you. Thanks for having us.
Yeah, thanks. Have a good day.
Thank you for joining us.
Thank you.
All right. So I know we have a little bit of time, and I just wanted to kind of keep it open to how I can best help you all, or how we can have this conversation. I know we had kind of planned for a little bit of a longer session, but kind of take the conversation in a different way. So Camille, what are your thoughts in terms of kind of the next steps?
Like a 30-minute or 25-minute med school 101.
25 minutes going. Okay. That sounds great. I can go through that pretty quick here. And I know some of y'all may have not been able to attend our session last fall. So we can definitely kind of do a shortened version of that, and also just kind of keep it open to questions. So feel free to type questions in the chat as I go along through this, so that at least I can answer some of those questions live as well. But like I said, we can definitely answer additional questions as we go along. So let me get my presentation up here. All right. Well, thank you so much. We really appreciate this opportunity to be able to present to you all and share a little bit more about kind of the med school admissions process. And, I know you all, many of you are either first, second, third years, maybe fourth years getting ready to apply to medical school. But this presentation is primarily just to kind of give you a base level understanding of some of the things to consider as you are getting ready to apply to medical school here. So today we'll kind of talk more about kind of the preparation process for applying to medical school, and also share a little bit about the application process, just to kind of help demystify that a little bit as well. So you want to become a doctor. I'm assuming most of the group in this chat here is interested in medicine. And first of all, I want to congratulate you all for starting this journey, because it definitely can seem like a long journey, but it's a journey that's well worth it. And even just hearing Dr. Lachlan and Dr. Ainsworth kind of sharing some of their experiences and some of the things that they're dealing with on a day-to-day basis, it's just amazing some of the things you get to do as a physician. And that's just a kind of a very small snippet of the field of medicine. So this is something that you'll be able to do as future physicians, and we're really excited that that you're on this path. So I kind of want to share just a little bit about the road to becoming a doctor, and many of you might know a little bit about this. But I like to share this image because it kind of gives you an idea of some of the different pit stops, if you will, or different destinations that you have to reach as you become a doctor. So obviously, most of you are in this pre-med chapter of your education, completing your 4th year or 4 years of bachelor's, or maybe 4+ years. And this is kind of the base level, if you will, requirements in terms of becoming a physician or going to medical school. So making sure that you have your prerequisite courses. And I know some schools are kind of shifting away from having specific prerequisite topics or prerequisite courses, but typically we definitely encourage individuals to take biology, physics, English, and chemistry, just because those are courses that you're going to be, you'll experience, especially when you take the MCAT, which is a huge component of applying to medical school. And then there are other pieces of your educational experiences, such as community service, leadership, and medical exposure, that are going to be important too as you're applying to medical school, because these are, I would say actually, these are kind of some of the most important pieces of that, because some of the other aspects of the MCAT and taking these courses, obviously you want to do your best on those, but the community service, leadership, and medical exposure experiences are what differentiate you as an individual becoming somebody interested in going into medicine, and that's what's really going to help create that story of, why you want to become a physician. Then once you get into medical school, you apply to medical school. Hopefully, you get accepted into a great medical school here, which will be about 4 years. Typically, be a 4-year program, which is first 2 years kind of didactic courses, and then in biosciences, you learn problem solving, communication skills, professionalism, and ethics as well. We spent a lot of time. We talked about ethics today, and a lot of our conversations actually, we spend a lot of time within our medical school talking about ethics and infusing ethics in different parts of our curriculum. And that's something I know a lot of medical schools are doing. So this is a topic that you're going to be consistently exposed to, and that you'll kind of get to understand as you go through medical school. Then when you get to your 4th year medical school, when you're getting ready to apply to residency, which is the next step, you go through this process called the match, where essentially it's I like to kind of say it's sort of like the NFL draft, if you will. You go interview with different medical schools, and then you rank the ones that your top ranked schools. So in terms of from the highest rank to the lowest rank, in terms of the schools that you're most interested in. So you rank those schools, and then they rank their applicants. So there's a system essentially that looks at the rank. So it will take an individual who ranked that institution high, and then you rank them high. So you have a higher chance of matching into that medical school, or sorry, into that residency, depending on kind of how you rank and how they rank you in that process. And then once that happens, we have a great event called Match Day, where you learn about where you're going to get into residency. And this is typically, I think, on March 15th. So usually what happens that week, right before match day, you'll get a letter saying that you matched into a medical school. And then if you do match, then you just have to wait until typically that Friday, where you actually know where you're going to go, because you don't really know where you're going to go to residency until match day, essentially. So so that's why I say it's kind of like the NFL draft, where you're kind of waiting until a specific day to kind of see where you're going to be going to. But then if you don't end up getting that letter, or if you get a letter that says you didn't match, you go through a process called SOAP, which they'll try to identify the medical school that you go to will try to identify residencies that hold open slots. Maybe they didn't rank everybody, or not everybody ranked their program high. So they'll try to fill those slots with those individuals. So most people, I would say, who go through this process do match, but sometimes there might be individuals that don't match, but they'll try to find an opportunity for you to match into residency. Then you go complete residency. You'll spend about 3 to 7 years, depending on the residency program that you choose. So if you go into internal medicine, you go into pediatrics, or you go into some of those, especially those kind of primary care specialties, then it's typically about 3 to 4 years. But then if you go to neurosurgery, for example, that's a 7-year residency, especially given the complexity of that field. So you spend those 3 to 7 years in residency, and then if you want to subspecialize even further into a specific area, then you're going to do a fellowship in another, maybe adds in like another 1 or 2 years, or maybe sometimes 3 years in that subspecialty area, to now kind of focus on that specific area to practice. And then, so then once you finish residency, now you're a full practicing physician. You can practice anywhere on your own, unsupervised. But education doesn't stop there. You have to continue to keep your license going. So typically every few years you have to recertify to keep your medical license. So you want to continue to, expand your education there. So I like to show this just to kind of give you an idea of that road, because it can be a long road. You start adding these years up, you're like, man, this is a long journey. But I always tell students that, once you really start on this road, it's really like you're already in it. And at Mayo Clinic and a lot of places, we call a lot of our students, especially our medical students, student doctors, because they're already in this field. It's just that you get more responsibility the longer that you get through that training process. So I say, so don't look at it as like, oh, it's going to take 10 years to be a practicing physician. Pretty much once you get into medical school, you're already starting to see patients. I mean, with limited supervision, but you're already kind of in that experience, you're in that space. So really look at it as sort of a part of the journey, a part of that training process for all these years. So kind of some of the things that you want to start doing now, sometimes we still, this might be a joke that starts at birth. There are a lot of people that switch into medicine. You don't necessarily have to know that you want to be a physician right away. Like at Mayo, we've had people who've been opera singers, we've had people who've been in business, lawyers, we've had people in the military that have decided to go into medical school. But I think the most important thing is really to kind of start building those great skills, especially those great study skills, because you're going to be doing a lot of studying in medical school and in residency and beyond. So you want to build some of those great, good study skills, expose yourself to different kind of content and course material, and also explore different experiences. You don't have to necessarily always just be a physician. And just to make sure, y'all seeing my screen? Just to make sure. I think I just wanted to yeah, I think it's good there. Um, so yeah, so you want to make sure that you expose yourself to different courses and different experiences. And a lot of people sometimes maybe don't think about other areas of their experience. So let's say, for example, you're interested in volunteering in certain communities, or you're interested in research or science. There's so many other experiences that you can have that you can augment to help you, especially get into medical school. So don't necessarily just think about medical school or getting into medical school as one thing that you have to do. Make sure that you're a well-rounded individual who has different interests, maybe music or maybe art or sports, advocacy, those types of things. I think those are really going to be important aspects of medical school. So in terms of some of the organization piece, it's really important to start keeping a good list or resume of experiences, because this is what's going to help you when you start to apply for or medical school. When you fly through the AMCAS application, you're going to have to document all the things that you've done, the dates and the things that you've done, the places. So start keeping track of everything now. And actually, this is a really great way to start pulling together what's called a CV, or curriculum vitae. And actually, it's a very important document for you all to start keeping track of. So keeping track of your presentations, publications, any like teaching opportunities. Maybe you're a student teacher, or maybe you're, maybe volunteers at specific places. You've gotten different awards. Keep track of every single thing, because one thing, especially when you go into medicine, and depending on the kind of institution you go to, but I'll say even just getting into medical school residency is having a really strong CV, to make sure that you keep track of all these things, because that's what's really going to help you be a competitive applicant for medical school and residency. And then even when you become a physician, at Mayo, we have a thing, and a lot of institutions have a thing called academic rank. So they'll take a look at all the experiences that you have. So if you have, 10 publications and 5 research posters and all these different things, you can actually have a higher rank, academic rank in that institution, just because you've done all these different things. So that CV is really kind of your currency for becoming a physician. But really at the end of it, just have fun. It's a long process. So just make sure you enjoy it too, because it can feel like a lot of work. It can feel like, oh, I got to do all these things. I got to go to this talk, or I got to volunteer at this place, or I got to do this research project. I mean, think of it as like an opportunity that you get to do and really have fun with it, because if you do something that you're not enjoying, just, it's not really worth doing it. So just make sure you have fun along the way as well. So the curriculum piece is something I just want to kind of touch on real briefly. And typically when you probably see a lot of schools, medical school requirements, usually you'll see it's a 1 year of bio with labs, 1 year of physics with labs, 1 year of organic chemistry with labs, and then or inorganic chemistry, and then 1 year of organic chemistry, and then a biochem course. So typically these have been most of the prerequisites for medical schools. But like I said, a lot of places actually kind of are moving away from um, prerequisites per se, just so that they can open up to a larger swath of individuals from different backgrounds. So like I know at Mayo, we don't have these requirements anymore. However, it's still important, like I said, to have a strong science background, just because it will help you when you take the MCAT, and just kind of give you a good foundation, because those first couple years of medical school, like I said, you'll be spending a lot of time, especially in kind of the science, bio related courses. So I think having a good background, anatomy is also a really great course to take in undergrad. So if you haven't had that as well, you should definitely look at that. But other courses like, Calc, English, psychology, sociology are really great courses to also think about taking as well. So the MCAT, I know that's sometimes it's the dreaded MCAT for a lot of people. And I do want to say, the MCAT it's just a tool for medical schools to assess kind of where you're at and kind of understand of all their applicants how well that they're doing, or how well they're doing in terms of their science knowledge and skills. But it's not really it's not a great test of intelligence. It's not a great test of your aptitude, or even just your potential as a physician. It's really just an exam just to understand kind of your basic understanding of medicine and science. So I always tell people, don't worry if you don't do well, especially if you take exam or the practice exams, or you take an exam and you don't do well. Don't take it as like I'm not good enough. Just take it as an opportunity for you to know, okay, these are the areas that I can improve on and work on. I mean, it's unfortunate, because I know some groups sometimes can struggle with MCATs or struggle with these standardized exams, and there are schools that are moving away towards removing the MCAT from their admissions process. Mayo is not at that point yet, but I know we've had a lot of discussions about doing that. But I know many schools are starting to consider doing that. But it's still, for most medical schools, you're going to be taking the MCAT. So definitely spend some time, doing that, especially for some of y'all who are first or second years who might think, oh, I'm not going to take it for another 1 or 2 years. Start studying now, so that at least you can get a good foundation, so that by the time that you get ready to apply, you kind of are used to it. You know the question banks, you know the kinds of material you have to study for. And there are a ton of resources. I'm sure Camille and Nina and her team have a ton of resources they can share with you, but there's also a ton online that you can definitely study, that you can use. But just a little bit about kind of what's on the MCAT if you're not aware. There's 4 sections that are in the MCAT. You have the bio and biochemical foundations, critical analysis and reasoning skills, chemical, physical foundations, biological systems, and psychological, sociological. I won't read through all that, but so these are kind of the core foundation pieces of the MCAT, just to kind of get a good understanding of that. And then in terms of the cost of it, and I want to actually make sure just to this is updated, but I know in the past the cost was $320, which has gone up quite a bit over the past several years. And I know sometimes it could be a barrier for folks, but there are resources such as the fee assistance program that can help cover that cost, especially if you have difficulty paying it. So definitely look into those resources. And also there are a lot of free resources or low cost resources online to help study for the MCAT as well. So you can take it multiple times within the year, but you want to make sure that you test early in the year, so that if you might take it more than once, that at least you have some time to go back and take it again if you need to, especially if you're going to be applying that following season. But I always say just start taking practice exams now, just kind of see where you're at if you haven't started already, just to see, okay, am I doing well, or do I need to kind of work on improving that? So just make sure to start thinking about it early if you haven't started that process. So I'll just kind of go over, and it was a lot of information here on the MCAT, so I won't get too deep into this. But I know one question that we get a lot is, if I take the exam multiple times, is that going to look bad on my application process? Or if I did bad on one and maybe did better on the next one, is, how do medical schools look at that? And typically most medical schools, but I will say Mayo Clinic in particular, we primarily focus on the highest score. So we don't necessarily care if you did really bad on one exam, as long as you we take the higher score, at least in terms of where you're at. Some schools might take an average of those scores, but I know most schools now are kind of moving towards taking the highest. And I think I got a question here. Does the amount of times you take the MCAT matter? It really doesn't. I know there are limits in terms of how many you can take per year. And I don't know if it was on that last slide. Yeah, you can take up to 3 times per year in a single year. So you do have limits on how many times you can take it. But most medical schools don't care if you took so many times to take it. They'll take the last score, the highest score. At least for our medical school, we take the highest score that you have on the MCAT. So if you take one exam, you did really well, and you wanted to see, let me see if I can take it again, and you score lower, we'll actually take the highest score that you've had on the exam. So a lot of preparation, just study, study, study. I think this is I'll probably hammer this many times, but just make sure to be prepared, making sure you take some time to get some resources, get some flashcards. I know there's continuing to be a lot more resources today than there has been ever. So and there's really no excuse, I think, to say, oh, there's not resources out there. There's a ton of resources. You just have to spend some time finding those. And you might want to, yeah, consider taking a commercial course. Sometimes those do help, just to kind of have that structure, if you will. And I know Camille and Nina probably know really well about some of the resources that they may have available for you all. In terms of the actual studying process, you want to make sure you take some time to, as you study, don't overwhelm yourself. Try to find a good study pattern or study schedule. So if there's certain days of the week that work best for you, maybe you have a little bit of green space in your academic calendar. Maybe set one day on your calendar to specifically study for the MCAT, if that works for you. But maybe it's like, oh, maybe I have like 10 minutes here, 10 minutes there, in between classes, or on the train going back home, or different times of the day where you can kind of pull out some exam resources. So just make sure to kind of spend some time reviewing and taking time to really see this, because you don't want to be cramming. You don't want to be taking this, start studying like a month or two, or maybe you're really good at that, but most people, I think, need some time to study. So try to make sure that you expand that study time, and take care of yourself during this process too. I think this is also a good foundation for you when you get into medical school, how to study for these kinds of exams, because you're going to be taking exams. You're going to take the step 1, step 2, step 3 when you're going through medical school and into residency. So getting used to these kinds of experiences, I think, will serve you really well. So I just want to kind of move on to the AAMC and some resources that we want to share with you. If you're not familiar with this, make sure to get familiar with the AAMC website. They have a ton of resources, a bunch of resources on different kinds of programs, AMCAS resources, clerkships. This is probably going to be your friend for a long time, because AAMC, the Association of American Medical Colleges, is kind of the accrediting body for a lot of medical institutions. So this is going to be a resource that you're going to be utilizing for a long time. So make sure to go get familiar with their website. Just go to aamc.com or .org, and there's a ton of resources from people for pre-med individuals, medical students, residents and fellows, and physicians. So you're going to be utilizing that resource a lot. And extracurriculars, it's definitely important for you to start thinking about those if you haven't already. We like to tell people, there aren't specific extracurriculars that we're looking for. It's like whatever matters to you matters to us because, we're looking for individuals who are really passionate about what they're doing. So whether, like I said, whether you volunteer at the local food shelf or whether you teach students on the weekends or evenings, you're like a biochemistry instructor, or you're into sports. Maybe you're a basketball player or football player or tennis or racquetball, pickleball, just whatever is important to you, I think is going to be most important to us. And having a passion for that is really what's going to stand out. So just find those things that really make you happy and focus on those things. And think about, and if you don't know exactly what you want to do, maybe think about things that you feel can make an impact, not only to you, but to other people as well. And try different things and seeing what sticks, what kinds of activities that are going to be most impactful to you. Summer opportunities are also really great. So make sure, I know summer's coming up now, and I'm sure y'all are excited to get to summer. But make sure to take advantage of the summer because I think that's kind of where most people can really dive into some of these experiences, whether it's um, a, a program like a pathway program. We actually have a ton of pathway programs, and hopefully my colleague Rhonda will pull some of our pathway programs at Mayo Clinic. But definitely start considering some of those pathway programs. We have one program actually that maybe some of you might be interested called the Undergraduate Plumber Scholars, which actually Rhonda is the manager for that. And it's a really great experience because it gives you a lot of potential mentors. You get to do shadowing. We provide a lot of resources for MCAT prep, personal statement writing, those types of things. So a lot of great programs. I know Mayo, we have a ton of those kinds of programs, but other institutions too have those kinds of programs. So definitely apply to those different summer opportunities. But also getting some research experiences too. Like if you're interested in doing research, there's a ton of that stuff, I'm sure, at Hunter College. But also other institutions, you can go to the NIH. The NIH is a great resource for summer research projects or research programs. So definitely look into that. Medical scribing, these are kind of different ideas. Shadowing physicians, if you have an opportunity for that. Volunteering and internships can really be helpful for getting that experience. So just lastly, the AAMC, ton of resources there, ton of programs that you can also find on their website. So the last piece of it would just be talk about the application process, and then we'll open it up to questions here. But I do want to say, with this application process, if you take one thing from this presentation, starting early is the best thing to do because, if you start applying, even when the application process opens up, if you apply late, you're limiting your chances for getting an interview and you're limiting your chances. So it's best to start as early as possible so that you can get yourself ready for that process. And I can see, this is kind of an image of, that it can seem like an uphill battle trying to do all these different things. But preparation and making sure that you understand the process is really key to growing in that space. So just a couple of different resources for that as well. The AAMC MCAS process. The MCAS is where you apply for medical school for most allopathic medical schools. And then there's also the ACOMAS, which is also for osteopathic medical schools. And then Texas has their own application process as well that you can look at. So in terms of the application itself, and we'll specifically dive in on the MCAS because that's what, at least at Mayo Clinic, we focus on. These are the different aspects of the application process. So these are the different pieces that you'll be looking for as you apply, that you're going to be putting in your biographic information, post-secondary experiences, all the things that you've done. And that's why I talked about having the CV is going to be really important as well. So this is where you're going to put a lot of that information into the system. So also some resources, like I mentioned earlier, that can be helpful as you apply is making sure you connect with Camille and her team, with Nina, to really kind of understand some of the resources that, that I'm sure they have some great guidance for you all as you apply to kind of pull these pieces together. But you can definitely also reach out to medical school specifically, and we'll make sure that you have our contact information. But you definitely reach out to us as well. And then one last thing, and I'll kind of wrap it up here, is the MSAR is a really good resource. It's become an online resource. The reason why I wanted to share that resource, the medical school admissions requirements resource, is that it gives you an idea of some of the different medical schools, what their requirements are, all in one publication. So at least you can go in and see, okay, what's the average MCAT or the average GPA score for these different institutions, and that can be very helpful too, because then you can know, okay, what do I need to prepare for? Do I need to have like a 90th percentile MCAT score to be able to get into this school, or do I need to have a 3.9 GPA for this school? And I do want to mention, a lot of schools will publish their GPAs, they'll publish their MCAT scores, um, and most of the times they'll put a median score or average score. That's important to kind of think about because the median score, we publish our median scores, and our median scores basically mean that 50% of the people are above that score and 50% of the people are below it. So our like for example, our median MCAT is typically like I think um, like a 520 or so, and then our median GPA is usually like a 3.9. So that means like people are above that and people are below that. So you might see that and like, man, I don't have 3.9 GPA or 520 MCAT. But what that means is that, okay, if I don't have that, there are people that have scores below that. So don't worry too much if you're not necessarily at that. You definitely want to shoot for those scores, but make sure to kind of take that into consideration when you're applying because some people kind of exclude themselves too early because they think, oh, I don't have that score. And you can talk to the schools too and ask them, what are kind of your cutoffs? Some schools do have medical school or MCAT cutoffs or GPA cutoffs where if you don't meet that score, they won't really move you through the process. So, you can ask for that information because that can be helpful too to give you an idea, should I apply to the school or not? Or what can I aim for when I apply to the medical school there? So with that, want to just kind of stop here and open it up to questions if there are any questions. I know there's a lot of information to share, but we can definitely go and share some more information too if you have any additional questions. Otherwise, really appreciate you all and connecting with us, and hopefully you enjoyed those cases earlier today. I thought they were really interesting, and hopefully get some more experiences like that. But with that, open up to a couple questions, and then we will wrap it up here. And thank you, Rhonda, for putting some of our contact information as well. So feel free to send us an email if you have any additional questions. We're definitely happy to answer some of that as well. All right, I think give it a minute here. Otherwise, I will let you have the rest of your afternoon off. So just had a question to come in. So how does schools look at students who have full-time jobs to pay for undergrad? We may not have and many extracurriculars because of this. I just wanted to know how it's worked before. So yeah, a lot of medical schools understand that you know you may have to work to be able to take care of your family or to take care of yourself to pay for medical schools. And we actually have many students in our programs who actually have been in those situations. So they're not necessarily going to look at you negatively and say, well, all you did was just work and went to go to school. They understand that people come from different experiences and different backgrounds, and they want that. They actually invite that because they know, you know, having individuals who have those experiences are what makes medicine better. So if you haven't had the opportunity to do a lot of extracurriculars because you've had to work, it's important to mention that in your essay and talk about, some of the reasons why maybe you didn't have an opportunity to do a lot of shadowing or to do research or to do all these things. because it helps them understand, that it wasn't that you didn't have interest in those extracurriculars. It's just that you didn't have the opportunity or the time to be able to do that. And most medical schools are pretty understanding of that, and actually they can be very impressed if somebody who is really determined, you know, on top of having to do medical school or apply to medical school, do school and all these different things and balance all that, it can actually be very helpful. So don't necessarily look at that as like a negative experience. As long as you are able to explain that and share some of the reasons why maybe you hadn't had a chance to do other things to help prepare you for medical school. Besides the main science and math courses, sorry, it's moving here. What kinds of courses would help a student be a more competitive applicant for medical school? That's a great question. I would say, you know, there aren't specific courses that the school is looking for that will say, okay, well, this person didn't take this course or that course. It's really up to you. Like I said, we've had people who are English majors who apply, business majors. I think it's really about taking those courses that are going to be instrumental in your decision. Maybe there might be a course that you've taken that can help you illuminate why you want to become a physician or give you a different experience. So like, let's say psychology, psychology is a great course to take because, it's definitely a study of the human mind and experiences of people. That can be very helpful to think about. But if you don't like psychology, it doesn't mean you have to take it. It's just as long as those courses are going to be helpful for you as you think about your future as a physician. And maybe not, maybe you love math. You have people who are math majors who, as long as they've done well in their science courses, have done well in the MCAT and have exposed themselves and I thought about why they want to become a physician. I think that's really more important than that specific course. But yeah, just make sure to kind of identify courses that are going to be helpful for you. So I think how ethics and even just courses that maybe speak to or help you understand um, the kind of the state of healthcare today. So we talked about ethics earlier. The state of changing laws, and having so political science as well could be very helpful just because it gives you an idea of laws and practices that are impacting the field of medicine. So those different types of things that can help you be a more well-rounded physician. Would having a full-time job be excused for not having a very high GPA? Um, yeah, I don't want to say excuses might not be a good word to put there. You know, like I mentioned earlier, if your GPA is lower because you had to work, you had to do all these different things, and you don't have anything to kind of remedy that. I mean, let's say if you're applying this year and you really want to apply and maybe you're not able to take, because a lot of times students, if you don't have a high GPA, you could take additional coursework after you graduate, maybe do a master's. I know a lot of students do that, or do like a post-bac medical program, which can also help too as well. But you want to think about it as, different levers. So if your GPA is lower, then maybe one thing you might want to really focus on is the MCAT to help strengthen that academic piece, because we want to be able to know that you can handle the academic rigors of medical school. So if you have a low GPA and a low MCAT, that might limit you in terms of the school's confidence that you can handle that curriculum. So you do want to make sure that if for some reason you say, hey, no, I just really couldn't do well because of my work, to explain that and then kind of showcase other areas to show, hey, I can actually handle this, because I'm done well on the MCAT, and this is something I've been focusing on as well. I'll take one more question before I close it off here. So, what if we have to take a science class late in the semester? For example, I want to take a biology and chem lab, but I can't because in Hunter all the classes get filled very quickly, and we can't do e-permit. Also, for biology, it's only given in the fall, which is this fall semester, and it's also full, and you have to wait until next year. So what should I do? Um, so if you're planning on applying this coming cycle, like I was mentioning earlier, some schools, they may have that as a requirement for biology. Some schools may not, or taking that chem lab. If you aren't able to, one thing you can consider is maybe applying next year so you can take those courses. So let's say you apply, you take a summer course, or you take something in the fall after you graduate. I'm not sure if you're where you're at, but you can also decide to kind of take some time, maybe graduate and take those courses after you graduated, so at least that you have that. But like I said, it depends on where you go to school, where you're going to apply to medical school, and it does help, especially when you're doing that and also applying for the MCAT as well, just because it gives you a good foundation. So I think it's a good plan at least to try to take it. But I understand that if you can't get into the course this year, you may not. Another actually potential idea is you can also consider, applying to another school, or like taking that course. I'm not sure. I know some students sometimes are able. Maybe Hunter College has a relationship with another institution that may have that might be able to take in students from other institutions. So you might want to consider taking a biology or chem course at another institution, if that's not available at Hunter this year. So that could be something you could consider as well for that. So yeah, thank you so much for the questions. Feel free to send us additional questions in the email. Wasn't able to get to all the questions here, but we'll make sure to get in touch with you all. But really appreciate this opportunity for us to present, and good luck with everything. We're really excited that you're on this path, and we'll hope to see you on the other side here soon. All right, thank you all.